So we have an incredible fount of knowledge, experience, and wisdom here, which is going to be oriented towards assisting our CTAF panel in voting on the questions that we'll have listed. I'm going to remind our panel and perhaps the public members who haven't seen the CTAF approach before how we go about doing this. It's a series of votes on the materials we've heard in terms of clinical effectiveness and health system, clinical value and health system value. And I think Matt is going to be controlling the slides, and we see our first example of such questions. This is the same format that we'll be looking at. And it'll take the format of, is the evidence adequate to demonstrate that intervention A is superior to a comparator B for patients with condition X? And it's not too hard to see how that relates to what we were talking about this morning, and the panel will be asked to vote yes or no. The panelists all have this complicated remote control device, generally known as a clicker, and you'll be able to vote 1 for yes or 2 for no, and we'll see our answers go up on the screen. We'll give you a chance to see how all the votes total up and make sure that everybody voted as they wished, and if anybody wishes for a quick revote because of a thumb slip, we'll ask folks to vote again at that point in time. So let's go to the next slide, Matt. This is the care value construct. So look at the bottom first, and we're going to look or ask our panel members to consider the comparative clinical effectiveness, what Jeff presented, the incremental cost per outcomes achieved based on what Dan presented and some supplemental information provided by our public commenters, any additional benefits above and beyond the simple clinical outcome measures that Jeff reported on, the contextual considerations, the kinds of stuff Ken was talking about earlier, to arrive at a vote on care value, which is going to be categorized as either low, reasonable, or high. That's the same format we've used before. Then we take that care value and look at the dimension of affordability from the perspective of the PMPM, the second analysis that Dan led us through. From the payer perspective, and Alex asked about Medi-Cal, and yeah, I guess we really should do this from the Medi-Cal perspective, which we'll draw out in our discussion, probably has a higher disease burden as well as the higher cost of implementation. For an overall assessment of health system value, which again will be low, reasonable, or high. Karen points out that the panel has the colored sheets, which some of you already have out, through which we'll ask you to jot your thoughts, because we do want to collect them for purposes of our write-up afterwards. And we'll also be asking you to share verbally, if you're willing and able to, the kinds of considerations that went into your assessments of low, reasonable, or high value, or yes or no. So in an effort to just practice our technology, don't want any hanging chads, we're going to do a practice voting question. Can we have the practice question, please?
Sure. So for those of you who haven't turned on your remotes yet, I'll walk you through a brief tutorial again. It's very similar to what we did last time, in fact, identical. So you can hold the power button, which is in the upper left corner of your remotes. And once it powers on, it's going to ask you for a voter ID. Now, those are on the Post-it notes that are on the back of your name tents, so each of you has a unique number. And once you enter in your number, you can press send to join the session.
Join? Sim?
Send or join. Yeah.
Where is that?
The join button will be the upper right button.
I get it, okay.
So it looks like we're waiting for 2 more people. 1 more.
Everybody vote.
And now you should see...
I haven't voted yet.
Oh, nobody's voted yet. So you should see 6 options on the screen in your keypad. And you can use the up and down arrows to select the option that you'd prefer. And then you can press send to enter in your options.
How about
I think I voted incorrectly.
How about just
Right, because those are numbers, and on here,
So if you
was
voted
it
in,
the number?
so if you voted incorrectly, you can actually change your vote.
Oh, there you go.
Explain the number letter aspect of voting.
So these will just be A through F will
Okay,
correspond. They'll match up perfectly once we're actually in the
Fenway
voting
Park
session.
is C?
Fenway Park will be C, which is the correct answer.
How do you get to C?
The up and down arrows.
This is not good for people whose eyes are beyond a certain age.
Oh, okay.
Yeah. Voting?
Oh, okay.
So we've got two more. One more. All right.
Okay, let's see.
Oh. All right. 1 second. I'll just have to restart this really quickly.
It's astounding how technology has simplified our lives.
So unfortunately, we'll have to redo that vote.
Yeah.
All right, so you'll also have to rejoin the session, unfortunately.
Okay.
So the same instructions as before, all of your keypads should have turned off, so you can turn them back on and re-enter in the number and hit join again.
Might be a little hard to hear unless you get closer. So everybody's got to
Apologies.
rejoin, then vote, then send. Okay, voting again.
Mhm. All right. There we go.
Okay.
Oh, we've got a tie.
Okay, so it looks like our voting technology is now indeed working. Right? So do they have to do anything now before our next vote?
Nope, not right
Nothing.
now.
Okay. So I'd like to pull up our first question. Remember, Jeff explained that the bulk of the studies that he was looking at and summarizing, and certainly the bulk that Dan was looking at as well, were in terms of the CCM model versus usual care. And I expect us to have a great deal more discussion about usual care as soon as we get into our round table later. But at the moment, question 1A, is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care using the collaborative care model have better outcomes than usual care in terms of improvement in anxiety and or depression? 1 for yes, 2 for no. So you don't need to vote yet, because if you have any questions about the evidence or about the question, we have rich resources for the panel to draw upon to help inform their vote, sort of like the California propositions. You can... Any questions or discussion of this before we ask for your vote? In that case, we'll ask for your vote. 1 for yes, 2 for no. This is question 1A. Right. Just use your yes or no on the little LCD screen.
All right, so if everyone's satisfied with their answer, I can display the results. If everyone is satisfied with the answer, I can display the results.
Okay. People, let's see our votes. We have a unanimous decision for 1A that there is adequate evidence to demonstrate these better outcomes than usual care. That's first. Now we'd like to go to question 1B, which is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care using the CCM have better outcomes than usual care in terms of physical health outcomes in patients with diabetes? A specific set of studies that Jeff addressed. Any questions for our resources around that? And perhaps I think both Paul and Ken made comments about Jeff's entree into the field of whether these differences were of clinical significance and how much is required to be judged good. I mean, Paul, Dan, and then Paul, perhaps?
I have a question. In the integrated care model, there was a nurse practitioner or somebody that would follow up in a patient with diabetes, not only about behavioral health issues, but about the diabetic issues as well. So if the hemoglobin A1C improves, this could be because of the phone call that said, are you watching your diet, are you taking your insulin, or whatever, which would not be a consequence of a behavioral health intervention. It would be a consequence of the integration that has a nurse practitioner calling, even though what she's calling about happens to be, are you taking your diabetic meds? So, I mean, there's kind of a tricky little question there. I guess if you set up the integrated model, it doesn't matter what she's asking about, they have a better hemoglobin A1C in the end. So it doesn't matter if her urging has to do with behavioral health or not. Anyway, that's my comment. It's sort of a comment.
In the impact model, the nurses only focused on depression, and on the subset of patients with diabetes, the diabetes did not improve. When Caton subsequently did a study where the care manager asked about depression and diabetes, and in that case, diabetes improved.
Thank you. Now, knowing that, cause and effect, the improvement in the diabetic care really is a consequence of setting up the integration. So I guess my answer then would be yes, it does have an effect.
Pressed by the care manager.
Okay.
If I could just
We have a
make a
couple of people want to comment, maybe Ken, and then Alex, and then Meg.
I was just going to say that what you don't know, I mean, I think your thinking is correct, but what we don't know is how much of their ability to respond to the diabetes instructions is because their depression has been addressed and they can concentrate more, right? So it's kind of, you might say, an interaction. The studies haven't been done to separate out how much of the improvement in the diabetes. John, would you agree that we don't know how much of it is from the depression getting better that facilitates responding to the diabetes management versus just the diabetes management itself?
Okay, a few more on this, and then we'll get back to the public health clinical impact. Yeah. Alex?
Right, so this is related. Hemoglobin A1C is a laboratory outcome, and we're talking about physical health outcomes, which for diabetes would be microvascular complications, prevention of them. We're talking about retinopathy and nephropathy, which take at least 10 years to see those changes in those outcomes. I just want to be clear that we're voting on here are the health outcomes, physical health outcomes, and not laboratory differences.
Jeff, do you want to comment on whether we have evidence to address that?
Hopefully this is on. So yeah, there is no evidence addressing that yet. There aren't long-term follow-up studies that have looked at that.
So you point out a very important consideration in terms of the wording of our question. That intermediate outcome of A1C control is generally associated with the potential for future health outcome improvement. By specifying physical health, we might be narrowing the question to whether we have evidence only on that longer-term observable sequelae. I'm going to ask our ICER staff to weigh in. It's my impression that we're looking at the improvements in that intermediate outcome.
Yeah.
Our boss is nodding, so that's right.
Intermediate meaning hemoglobin A1C.
Correct.
Yeah. Yeah.
Okay, we have a couple of other comments, so let's hear from Meg.
Mine is along the same line. I mentioned this on a call last week, I think, that an even better, although still intermediary proxy for the true clinical outcome for diabetes is actually blood pressure control, where there's a higher correlation with true clinical outcome than the A1C decline. So my question is whether there's any evidence about blood pressure control in diabetics, which it would be a potentially more predictive than A1C decline in the ultimate true outcome, which is clinical improvement.
So in the Caton study, they also demonstrated a reduction in blood pressure and in lipids in the collaborative care arm of the randomized trial.
At a level of statistical significance, because what you're presenting here for A1C, the confidence interval almost, or actually does include, I mean, it's pretty low. So.
In the one trial, I think the A1C reduction was even greater and was statistically significant just in that trial. So that trial was very, very effective on and had statistically significant improvements, I think, in all three: A1C, systolic blood pressure, and lipids. I can't remember. I think LDL lowering. Though our experts on the panel may also be able to comment.
I believe the trial you're referring to combined patients with heart disease and diabetes, and then the care management spanned diabetes. John, am I remembering this? Yeah, I'd have to look it up, but I'm pretty sure you're referring to the New England Journal article. Is that right? Yeah. So that's heart disease and diabetes, and the care management was diabetes and heart disease, and some patients had both. Do you know what I mean? So in any case, it's not as, it's a little broader than the question is. It's kind of within the spirit of the question, but it's that particular study, which is cited a lot, is heart disease and diabetes. Yeah.
Thanks. And Paul,
with the lipid and the blood, right, so that it wasn't just diabetes being addressed, also heart disease.
Paul, your thoughts on the significance, clinical and population, of these kinds of changes?
Yes, I think it's difficult to interpret how important some of these differences are that are statistically significant, and I think it's risky to try to apply what you'd apply to an individual patient in terms of whether this is a clinically important improvement to a population where a certain percentage may have a huge improvement, a certain percentage may have no improvement, some percentage may be harmed, but the overall is a positive effect. And without knowing that distribution or without knowing what fraction had which type of outcome, I think it's hard to judge that benefit. And I think in the end, personally, adding in a metric like a quality-adjusted life year or something that we can compare across all types of diseases is what's helpful, and I'm glad that's part of this.
Chris, and then Mike, or
for the panel, is this one of the areas when you delve into the disparity literature you start seeing more significant changes?
Ken, did you want to respond?
I'm sorry, I was trying to look up the Caton article. Unless you have someone else who can do that. What was the question? I'm sorry.
The question was, is in things like diabetes or hypertension, are these kinds of interventions more significant in underserved populations?
I don't think we've seen that sub-analysis. John, am I right about that? Yeah, I think they were ethnically diverse populations, but I don't think they were particularly designed to look at the disparity question. That was more just in the depression intervention, although many, the average depressed patient has 3 chronic medical conditions, and typically they're hypertension, diabetes, and arthritis, right? And the physical, the physical functioning outcomes have been looked at in other areas like arthritis and pain management. The impact study, has that result. But I think the diabetes result, as I recall, is the strongest evidence is from the New England Journal trial. You mentioned the sub-analysis of impact where it wasn't significant. But other trials have lumped medical illnesses together, like the PIC study, but not looking in, then mainly it's the depression outcomes which are better in that population. But I'd have to look up Wayne's study unless someone were speaking to see how clinically significant.
So I just want to clarify what we're talking about when we say usual care in the context of this question. Is this the usual care of diabetes, in which case behavioral health is sometimes identified and then some go to this program and some don't? Or is this the usual care of a population of diabetics who are known to have behavioral health and some go here and some go there? And the reason I'm asking is because the usual care of diabetics often doesn't include screening, whereas in the second situation, they've been screened and now you're looking at the behavioral health piece alone.
So the question is, how are the patients for the trials recruited, I think, and then randomized?
Are we looking at usual care of diabetics who may or may not have behavioral health identified, as opposed, because then you're going to have some that it wasn't identified and they're going to be in the comparator group.
In Caton's study, they had both diabetes and depression.
Okay, thank you.
Any other questions? So with the modification, I'll just point out that once again, California is leading the rest of the country because all the edits and clarifications we make and work through here will be used in a couple of weeks in the Northeast states when this topic comes up again. So we're doing everybody a favor. So let's restate question 1B, is to say, is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care using the CCM have better outcomes than usual care in terms of an intermediate outcome in diabetes, the A1C? And perhaps we'll think for the next panel about looking specifically at blood pressure or a combined measure. But for now, the evidence we've talked about is on A1C.
Can I also suggest you talk about whether the care management addresses the physical health disorder? Because, I don't think it's fair to question whether an arthritis treatment improves hypertension, which is kind of how this question is reading now. If you improve depression, does diabetes improve?
So I think this gets at a question that came up on our staff calls and in response to public comment. And Jeff tried to explain it to us in terms of what the physical health subscale of these broad surveys really indicates. Jeff, could you help us understand that?
I thought 1C was really more getting at the, I take it back. I thought we had a quality of life questionnaire here, but the quality of life, the physical subscale of quality of life really talks about do any physical health symptoms impact your ability to go to work, to do the things you like to do, those sorts of things. So the physical health outcomes are all
just to clarify, if it's helpful, so in the study we've been referring to, the patients had poorly controlled diabetes, coronary heart disease, or both, and coexisting depression. The outcomes included the hemoglobin A1C difference, 0.58%. LDL cholesterol levels, the difference was 6.9 milligrams per deciliter, or 0.2 millimoles per liter. Systolic blood pressure difference was 5, on average 5 points, 5 milligrams or millimeters, and as well as the depression difference. And then there were care, so there was more frequent insulin doses, more use of hypertensive medication, and more use of antidepressant medication, and then also improved quality of life and satisfaction with care for diabetes, heart disease, or both.
So I have the trial up in front of me, and just looking at the primary results, they don't match exactly that, but in part probably because those are averaged at different time points. But at 12 months, which was the end of the active trial, the decrease in A1C was 0.56, the difference between the two groups. The difference in the LDL measurement was 9.1 points, and the blood pressure measurement, it was 3.4 millimeters of mercury systolic. And then those differences decreased over time. They follow in the post-intervention period, and they decrease at both 18 and 24 months.
So this discussion has brought out some really ripe areas for our roundtable after our next set of discussions, which are how do you target this intervention effectively at the group of patients most likely to benefit, do you see a kind of a halo effect over other areas of function and illness with counseling and contact, and how broad should the scope of that counseling and contact be? At least that's what I've kind of pulled out of this, and we'll come back to that. And John, ask your question again later when we get to the roundtable. Are we ready to vote on question 1B? In that case, I'll ask the panelists to pick up their voting gizmos and answer yes or no. So the answers represent a fairly even split, and I'm going to ask everybody if the question was clear and that's what they meant to vote.
That is our last best.
Do any of the panelists wish to redo this vote? If not, we will go on.
Vote just changed.
Oh, vote just changed.
Some votes are changing. So, I, on the fly, changed, a little bit of the wording of the question. Perhaps that was an issue. So can people give an indication of how they were approaching this question? That end of the table first. We'll do this like east-west.
Well, I voted no, only because this was the only study presented. I think that I'd want to see more evidence. I think this is a really important question. My experience as a primary care provider is if I don't treat the depression, I'm never going to get anywhere with the diabetes. But really the question is, what is the incremental benefit of treating with this model? And I'm not sure the evidence is really solid there yet.
Any comments from this side?
Well, I voted the opposite, mostly because even though there's a kind of a small number of studies, it's interesting that I found that it was, hemoglobin A1C is a lab test, but we've also got blood pressure, which I'm very interested in. And if you sort of see these things align, it's not fabulous evidence, but it is some. And so I kind of thought that while we don't have great evidence, the question is, it seems to be consistent. So I was sort of going along that line.
I think the question for me is, how should this be interpreted as, do I think diabetes is different in some way from people without diabetes and depression, or is there evidence, particularly in diabetics? And I interpreted the latter, and therefore had a higher standard, I think.
And the clarification with the intermarker was important.
Okay. Okay, does anybody wish to re-vote, or should we let the vote stand and think about, for our next discussion and vote, we'll clarify in terms of the intermediate measure, look at the blood pressure evidence as well. Very good. Let's go on to 1C. Is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care using the CCM have better outcomes than usual care in terms of physical health outcomes in patients with other medical conditions? Questions? Comments?
I have one quick comment. There are two good trials of collaborative care for pain that were both positive trials. Steve Dobzka and Kurt Kroenke.
Jeff, did you come across those?
Yeah, no, I know those.
Are those?
Yes. It's essentially the same model. They and they suggest benefit for co-management of patients with chronic pain. Well, one is cancer pain, one is chronic pain, and the results were suggestive of benefit of adding depression management to regular pain management.
And was that depression management in a usual care setting, or a traditional mental health care setting, or a behavioral health integrated setting?
So it was a collaborative care model approach.
Any?
Jeff, as you presented the slides this morning, the quality of life, physical health, quality of life is largely what I'm relying on in making my determination here. But the question as worded says with other medical conditions. Does that mean, I guess that summary slide about quality of life, were those studies in patients with other medical conditions?
Not specifically, but as the panel has indicated, most patients have several medical conditions if they also have depression. So I think those results largely apply.
Any other comments?
Other medical conditions?
We're on 1C.
Presentation slides.
Sorry. So on page 14 of the slides that were handed out, slide 28, other medical conditions, diabetes. So in this question, other medical conditions means which ones? This is diabetes. Other medical conditions other than diabetes?
I think other than depression. Is it?
No,
not other than diabetes.
Right. Oh, other than diabetes.
Other than diabetes.
Right. So you would have the heart disease and the diabetes,
okay.
heart disease, and you can't tease them out really in Wayne's study. In general, the collaborative care studies are a little inconsistent on physical functioning outcomes. Some have them, some don't, but not referring to medical conditions, just generally. And then you have isolated, particular studies showing benefit for pain reduction and arthritis of depression collaborative care, and the ones that that John has mentioned of pain in general, where you have lots of comorbid depression. So it depends on how you would read the literature, I think, what you would, how you would answer that. There's certainly evidence for it. Is it like overwhelming, as strong as improving depression? That's a different issue. Does that make sense? I don't know, John, am I
That makes sense.
being a little...
And Jeff, I think when you looked at the larger universe of evidence, you excluded some of the trials around heart disease specifically and COPD because those were administered in specialty clinics, not the primary care setting. Is that right?
Excuse me. Also some in neurology clinic. Yeah. Yes, that's correct. Most of the others, there's one trial in one specific condition, but not significant literature. So we didn't detail each individual study in the review.
Okay, so just help the panel. Were those two pain studies that were referenced in your overall assessment?
In the overall assessment, yes.
They were. Okay.
Question.
Yes, ma'am.
To the issue of quality of life, is there a question specifically related to that, or is that supposed to be understood as embedded in one of these other questions?
We have that coming up.
It is coming up. Okay, I missed it. Thank you.
Somewhere here. Yes. We have the quality of life kind of split, I think, but let's come back to that question and make sure it captures everything that's important here. Any other comments?
I think I'm a little confused about whether we were really given evidence to answer this question. Okay. Because if the answer is that for the other medical conditions, non-diabetes, the challenge is that most of those are done in specialty departments, and the scope of this review is really around primary care. I don't think we actually saw that evidence, so I sort of want to abstain because I don't think we've had a chance to look at that. So I'm hesitant to actually answer that because I haven't really seen the evidence. I don't know how other people on the panel feel.
Yeah, I think the only significant evidence I think that we were thinking about was the physical functioning quality of life scores. That in general there were individual studies in a few specific areas like cancer pain, but no significant literature for any other specific conditions.
Are you referring then to the SF-12 physical component summary?
Sometimes it was SF-12, sometimes it was SF-36, but yes.
So there's a funny statistical thing about the SF-12 is that they create a physical health summary score and a mental health summary score. They're actually orthogonal, so every question gets included in both scales, and it's really impossible to improve on the mental health scale and the physical health scale at the same time. That's perhaps why there's not a lot of the evidence, because you always improve on the usually the mental health component summary of collaborative care study, which makes it virtually impossible to improve on the physical health side.
No, you can. The health
Really
insurance
hard.
experiment, for example. That's,
On the SF-12?
well, the 36 is what.
No, Greg Simon's got that paper that shows that, talks about the orthogonal scoring of it, and that you can't get outcomes on both. Maybe you can on the 36.
So I'm going to take some lessons and experience from the governor of Indiana and suggest we withdraw this question and send it back to the legislature for additional consideration. Because we do have a subsequent question that will deal with those subscales, and we can come back to this question and how those subscales are scored. But we didn't, as has been pointed out, explicitly present all the evidence by other physical conditions or functional states like pain, and we'll take that as a lesson for next time, too. Dr. Pearson, would that be okay with you? That's okay with you. Okay. So we have tabled question 1C, Karen. Are you okay with that? Question 2A. Is the evidence adequate? As we've said before, that's integrating behavioral health into primary care, other than CCM, in other words, these integrated non-collaborative kinds of models that Jeff tried to speak of, and we heard a little bit more about from John and Ken, have better outcomes than usual in care in terms of improvement in anxiety and or depression. Is the evidence adequate for those other models? Questions again. Confusing area. Remember, we saw that levels of integration that doesn't really quite fit with what we mean by collaboration and all of that. So this is saying the non-CCM models, is there evidence for this? Any questions? In that case, I'll ask you to vote, yes or no. Okay, 13 votes are in. Okay, looks like the preponderance of the opinion is that we have not demonstrated that with the evidence presented. Any comments? Let's go on to question 2B. Is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care other than CCM, same category as the first question here, have better outcomes in terms of physical health outcomes, which we're now translating to the intermediate outcome in diabetes?
Could I just make a comment?
Sir.
I mean, what I would, since you're thinking of Medicaid and, and health home model, the only caveat I would suggest, because it's sort of out of the scope, it's one thing to look at interventions in a primary care setting. But, for example, home health interventions, and there are adaptations of collaborative care for home health that have been done that have been quite effective. That's, but you're not looking at home health interventions here. But if you're in a primary care practice, you are thinking about not just what's literally happening in your clinic. I think you're thinking about what's happening to your patients, including with home health and so on. So I just would say, you're commenting on literally what happens in the primary care setting as opposed to what happens to primary care patients.
That's a very important point, and I want to come back in the roundtable to ask about settings broader than a traditional primary care clinic. You mentioned community health interventions after Katrina, other settings for interventions, home, community, schools, other kinds of places. So let's come back to that. But for the purposes of voting, we're still looking at primary care
settings. Yeah. Okay.
Mike.
Actually, just to borrow Meg's point, we really didn't see any evidence on integrated care. All of the models primarily were the CCMs.
So Kim points out that we didn't actually see the evidence because Jeff told us what his assessment of it was. You want to remind us, Jeff?
There was no evidence. I shouldn't say. I mean, there are sort of descriptions of projects out there, but no comparative evidence.
Yeah, the main one that's reviewed, you mentioned the the SAMHSA demonstration, but that actually was a randomized demonstration. And they did not find a benefit of co-location, which is one form of integrated care in that particular study, as I recall. John, am I remembering that correctly?
Yeah, they randomized clinics in that study. They compared it to a facilitated referral.
Right,
So it was
facilitated
equivalent
referral.
to facilitated referral.
Right.
Which it doesn't really help address this question.
Yeah, okay.
But this goes back to a comment that we discussed earlier of it, not enough evidence versus enough, and the answer is no. And so we're saying no, but it's mainly because it's not enough.
No data.
Or there's no data.
No data.
That should be equivalent, yeah.
And may I make a comment about that, too? We had just a very brief discussion over lunch. It was more a philosophizing than anything else about what constitutes good evidence, right? So when we're talking about randomized control trials, that's one level of very rigorous evidence under controlled conditions. And then there's real life, on the ground, evidence that might be more observational in nature. And I'm just not sure what amount of that type of evidence exists related to models that are not collaborative care. And the argument that I think I would make is that you need both. You need, when you look at evidence, you need to look at the randomized control trial evidence, but you also need to understand the elements and the components of what it takes to implement those models in practice. So I'll just make that comment.
Just to follow up on that, it's a bit of artificial dichotomy, but it's often described as collaborative care having a lot of research evidence, and the other integrated models, such as the Cherokee Health System, is having practice-based evidence. When the FQHCs implement the Cherokee model, they think that it improves the outcomes for their patients.
Say what?
They think it improves the outcomes for their patients, but they don't study it in a rigorous research way.
Yeah, I mean, you're absolutely right. These qualitative methods, dissemination research, implementation research makes people like Jeff, break out into hives, but there are attempts to capture that richness. So, and I really like the idea of evidence-based philosophy. I think we should pursue that. So we still have question 2B in front of us, as described by Kim. Can we ask the panel to vote? The panel says the evidence is inadequate. Very good. Let's go on to question 2C, which is the third of our parallel structure questions. So for interventions other than CCM, do we have evidence that we have better outcomes in terms of physical health in patients with other medical conditions? Remember the long discussion we just had. Ask you to vote there.
June, we skipped this.
Oh, we tabled
it for the prior one. Why would we?
Oh, that's right.
Thank you.
We saved you from yourself.
Thank you very much. Let's go on to question 3 then. Is the evidence adequate to demonstrate that interventions to integrate behavioral health into primary care using CCM improve patient satisfaction versus usual care? Any questions about this? In that case, we'll ask you to vote.
Having trouble with my
One more vote. So the panel answered, yes, there is evidence that it improves patient satisfaction compared to usual care. Okay, we have just a few minutes left over during this section of our voting, and I'd like a little input from the panel on additional ways we might construct these voting questions in general or.
Did you miss one?
Thank you so much. My page was missing one. Q4. We have the same question again with respect to whether the other types of attempts to integrate BHI that Jeff described as having little published evidence improve patient satisfaction compared to usual care. More votes? One more vote? Does everybody think they voted? Because if so, we might want to vote. Oh, there we go. Okay, there's 13. And for this, we have the preponderance of votes being no. So at this point, I'd like to ask the panel to reflect a little bit on how they voted, their thoughts about the questions, and suggestions for focusing and really honing in on these questions for our next CPAC presentation in a couple of weeks. Any thoughts from the panel?
I have a question.
Please.
What were you, with the questions, the way they're currently formatted, what policy outcome were you looking for? What were you trying to dissect here?
So, Steve, I'm actually going to ask you to pick up a microphone here, because there's been a general question about whether CTAF votes have any teeth. Are they intended to be adopted as medical policy? Do they go into governmental regulation? And the answer to both of those specifically is no, but they are informative for the public discussion of these issues.
Well, I was actually just going to say that that's the exact first question, in a way, for the policy roundtable. Given these votes, how should they be then applied in the healthcare system to things like coverage or decisions by provider groups and materials for patients, et cetera? So they are to, in a sense, provide a basis based on an independent look at the evidence, but then the next step is critically important to involve the conversation of everybody at the table.
Mike, is that
perfect?
Other comments?
Yeah.
Bob.
It would be nice to have yes, no, and inadequate data so that you don't have to infer a no, meaning I think not versus I don't know. Or I can't make an informed decision based on enough data to make me comfortable.
We absolutely agree with that.
Thanks. We'll take that under consideration in our next staff meeting. And even though I seem to have lost a couple of pages from that, Matt reminds me that we have our most important questions coming up, which is now that we've talked about the actual health outcomes that we've seen, we go on to our value questions. So is our next one? There we go, number 5. Given the available evidence, what is the care value of CCM versus usual care? Paying attention to the factors on the bottom of the screen that are listed that should go into your consideration.
Could you remind us once again the difference between additional benefits and whatever that other one says? Contextual considerations.
Yeah, we've talked about this in a variety of ways. Sometimes the contextual considerations involve things that, like Ken was bringing up, that this is a stigmatized condition, that it's widely unrecognized, that there are access kinds of issues. The additional considerations might mean things like something is easier for patients and families to do. Like last time when we were talking about hepatitis, or the time before, it's easier to take a pill than take a shot. You know, these sorts of things. Other questions? Okay, so we're going to have our first care value question. Low, reasonable, or high? Give you a chance to jot down your thinking on your little sheet to capture your thoughts and vote. So with equal outliers, we had the majority responding that this represents reasonable care value. Comments? Anybody on the high or low end wish to give a sense of what was driving their vote?
Sorry, I was in the reasonable. I was in the middle.
Yeah.
But I raised my hand before you asked that. Right? But I was so tempted to vote high, and I think I probably would have been nudged to vote high if we're going to, if CTAF or if ICER will discuss this in the future, if evidence about reduced disparities is included in the report, that likely would have pushed me to change my vote.
Interesting.
I also voted reasonable, but would have voted high if we had evidence for the senior population, which I suspect would show a huger benefit and also is against a higher baseline cost.
Other comments? Jerry.
I want to agree with Alex and what he said because we heard things today that about disparities and also about impact on things like employment and so forth. And as I see it, the framework that we use with its talk about contextual considerations makes room for that kind of consideration to enter in. And those are pretty important. I learned things here today that were valuable.
I voted high, partly based on the idea of the additional benefits. I work in a community where we have mental health crises and suicide clusters, and I know painfully well how important those things are to consider in terms of reducing stigma and easing access, and those are things that are not specifically measured, but we know how critically important they are.
I voted high also, mainly because we're not here debating whether we should be treating diabetes or hypertension. I mean, we've got an illness, we've got a treatment available, and it works. It just seems like we should be taking advantage of it.
Any other comments? In that case, let's go on to the health system value question. Given the available evidence, what is the overall health system value? Up for discussion? Comment before we vote. Yes, ma'am.
Can I just ask a quick question? Has there been a comparison between chronic care model for the disease, kind of like the 5 core conditions, versus what we're talking about here? And whether there's a comparison, because if we're talking about whole person care, then behavioral health should be a part of it, and it's based on the chronic care model. So what is, what's the hot topic to debate?
A good question. I don't think Dr. Wagner intended to exclude, behavioral health conditions, mental conditions in the chronic care model. And we heard that this was an outgrowth of those principles and has some overlap with the patient-centered medical home. Would those most experienced like to comment? Ken, you have any thoughts on that?
No, that's exactly right. I mean, this is an adaptation of that broader model in this particular instance. Mm-hmm. And that's exactly correct. You're wondering why pull this out separately?
Yeah.
Well, maybe part of that is they're often separate funding streams, for example, and there are more silos. And then there's the debate as to who has responsibility for care, and all of that, policy context fits into what are we going to do, who's responsible for these patients, who's going to pay, how much is it going to cost us, right?
Those are our next questions.
Any other comments on that? Dan, and then Matt.
Question, we're voting on the health system value of collaborative care.
Yes.
And my question to Dan 1 is I'm going back to the old system now. The incremental cost of integration increases per member per month costs by what percentage? 0.5%, 1%, or above 1%?
So, in terms of the model that we did, the incremental cost of integrating behavioral health was, on a percentage basis, was 0.5% of the currently stated Medi-Cal PMPM.
Thank you.
Well, I want to parse the word low. So low can be thought of when we talk about low value care, high value care. Low has always meant that there's greater cost than benefit or greater harm than benefit. That it does not reach a standard of what we should be doing. That is how we've often talked about low value or no value care. Or low could be, it still exists, it's just not very high. So I'm really not sure how to interpret that here. And I wonder if someone else has a thought on how to interpret the word low.
I agree with your initial comments as long as in harm we include financial harm in a broad sense, not just clinical. Yeah. Anybody on the panel want to talk about how they interpret these categories of low, reasonable, or high?
Could I ask a question about the economics? So when you were modeling the costs using the AIM Center model, was that compared to zero? In other words, so the added value would presumably be over what that system would be having for mental health anyway. Whether, you follow me, like if it's a health plan perspective, then they're going to have some specialty care, and then, or you see what I'm saying? Like you have the psychiatrist, for example, but there would be psychiatrists someone's paying for anyway. So is this over and above what you would be expecting, or was this, here's what the model would require, and that's added over what?
This was intended to be over and above what the traditional approach would be. So we talked about new hires. We used the one published study that focused on the incremental costs of delivering an integrated approach over what had been done before. So this wasn't building a practice from scratch. This was layering in additional hires and additional infrastructure on top of what was already there.
Okay, and John, is that typically how it's done in the AIM Center, or are you repurposing people who were hired anyway, or a combination? Because I know
often the collaborative care model, I believe, involves hiring new staff. I think that's true.
Rather than repurposing.
Yeah.
Uh-huh.
I have a question. We're supposed to be looking at this from the Medi-Cal perspective. Yeah. California is moving away from fee-for-service Medi-Cal into
managed
Medi-Cal. So how does that play into your assessment of the impact on Medi-Cal?
So I think we had a little bit of discussion about this when talking about Medi-Cal versus Medicare, and so the base PMPM expenditure for Medicare would be higher than for Medi-Cal. I'd have to double check and make sure of the current commercial number for California, but I think that the current PMPM value for California commercial plans is a little bit lower than Medi-Cal. So if you think about it on those three bases, then that's a way to think about the additional investment. So,
is that what you were getting at, Meg?
I'm not sure. I think you did your assessment based on fee for service. Maybe it doesn't matter because it's all one bundle for the state. But if it's managed Medi-Cal versus fee for service Medi-Cal, I might imagine that with the incentives different, that the output or the resource utilization may differ. So I'm just thinking about where the puck is going, as opposed to where it's been for Medi-Cal in terms of how it's aligned. And so it's possible that the estimates of resource use will differ as we move into those managed models. So my question is whether this accounts for that or whether it needs to. Maybe you've thought this through and said it doesn't matter.
So we have not accounted for that shift, no.
Did somebody from the state want to comment? No?
But
Yeah.
if we're presenting information on a PM-PM
Just want to say
perspective,
that-
whether we're talking about capitation or we're talking about fee-for-service, we're talking about a baseline of expenditure that's expressed on a per member per month basis. So whether that manifests itself as an inflation in a capitated payment to account for this integration, or whether it's an increase in fee-for-service payments, it's in a sense immaterial. We're talking about the incremental cost to an ACO and how that would be reflected to the payer, regardless of whether the ACO is paid on a capitated basis or on a fee-for-service basis.
From the state?
I'm not sure that I understand the question, but if yes, what I think right now in California, 80% of the beneficiaries, Medicaid beneficiaries, are in managed care. So the fee-for-service is not. You are asking about fee-for-service compared to the managed care. So I'm saying that to date we should look mainly at the managed care population, at the PMPM, as we have very few fee-for-service. So I believe that this is what you did, right?
Thank you. Thanks for that clarification. Mike, you got the last word here.
Yeah, I'm going to go tangent here, not directly to the question, but for the panel or any Dan that wants to answer, when you consider the duals, which have close to 50% have psychiatric diagnosis, and their costs are through the roof, is there data around that group, and what does it tell us?
So yes, the duals would be much higher. The 552 represents the fully loaded Medi-Cal PM for the most recent reporting year from the National Medical Expenditure Panel Survey for California. That would include dual eligibles in the estimate. So this is Medi-Cal 552 PM, including dual eligible patients. If we had focused only on the duals, we would have a much higher base to start with, yes.
We have one last quick comment.
So if you look at across all commercial Medicare and Medicaid insurers, it's about 15% of enrollees have a diagnosis of mental health. That's missing a lot of undetected. But only 3% of all healthcare expenditures go towards mental health. So mental health in general is hugely underfunded. And it partly tends to be because it's stigmatized and people don't lobby for it. Ken has a colleague economist from RAND, who made the point that it seems like all quality improvement for mental health has to be justified by cost savings. And that kind of bar is not made for other disorders. So that's just something to consider for this vote.
Steve.
Just thought I'd take the opportunity, because the panel is still relatively new to thinking of the distinctions between care value and health system value, and getting back to Marge's question, I just wanted to emphasize again, care value, which is the first box here, remember it itself was made up of those 4 or 5 boxes that you had to consider: the incremental cost effectiveness, the comparative clinical effectiveness, additional benefits, all of that. So if you voted low care value, there is no way that isn't low health system value. If you voted reasonable care value or high care value, managing affordability is a toggle switch around which we are looking for potential harms due to the short-term budget impact. And that is because short-term budget impacts, if it's too high, can either lead to very rapid acceleration of healthcare premiums, which will affect access for everyone, and or displacement of other care that is of higher value to individual patients. So it's to look at that aspect of the possibility that short-term budget impact would, in a sense, degrade the care value provided to patients that you're meant to look at. And there is a definition for the panel in your material on page 4, if you want to look at it again.
Very good. Thank you. So I'd like to thank the panel. We're going to take a short break. I need to go see my primary care doctor and get a facilitated referral for my anxiety very quickly.
Jed. Hey, Jed.
Well, we're not going to.
They get to vote.
Oh, did we vote?
No.
Vote without me. Go ahead and vote.
Ed needs a break. Everyone else, please vote.
It's so good to have people looking out for you.
Collaborative care.
That's exactly right.
Collaborative care.
Okay, let's see the results, Matt. Okay, so reasonable and a sprinkling of high there. See?
So high.
Now we have 7 and 8 to go.
Now you're really scaring me. Reasonable and high, right. And as Karen pointed out, because we voted no for the other than CCM interventions, we don't need to look at the value aspect of that, right? So we are able to take a short break now. Let's make it 8 minutes, give or take a second. And we'll come back and get into our policy discussion, because that's so important around the payment and delivery system designs that Karen's going to present, and then we'll get into all the rest of this discussion we've been itching to get into. Thank you.